Ah, that's why it wasn't done with. Okay. All right. This is a hard one. So tomorrow I took the easy ones. The easy ones are treating diabetic retinopathy. So treating proliferative retinopathy and treating diabetic macular edema with a lot of our colleagues around the world is, I'd say, where 10 is really hard and 1 is really easy, it's like a 3 or 4. You have to sit down and learn how to do it and learn how to approach it. It's a 3 or 4, okay? Macular degeneration is a mess, okay? It's like a 9 or 10 right now. It might get easier with some new treatments or new devices for it, but we're just gonna talk about where it is right now, okay? And I hope this is way out of date within a couple years, because it's not so good right now. It's a common problem throughout the world, more so in some places than others. These are the disclosures that are relevant. I get grant support again from all these companies that are working on ways of treating the neovascular form of macular degeneration. Now the hard part is not the first day with the patient. It's the first day with the patient that you see somebody with vision loss from choroidal neovascularization. They don't always have vision loss, but if they do, the easy part is, oh, I know how to treat that. You're going to use anti-VEGF injection. Okay, that's the easy part. And if that's all it was, you just end the talk right here. And for some people, that's all they know. Okay? So we're going to spend 40 minutes telling you the rest of it that a lot of people don't get right now. I hope you'll get it. Okay? And if you don't remember, when you go home, you're welcome to write me and say, what did you say again? Because I got the first thing. I gave them an injection of an anti-VEGF agent. And now what? Okay, so we're going to talk about now what. Because it's a mess. It doesn't have to be. I'm going to tell you what's out there in the literature so far. And then hopefully we'll make it a little better for you. And I hope it'll get even better over time. Okay, so the question, I'm only going to discuss what happens when you first treat them and the first 2 years. The reason I'm not going to discuss anything after 2 years is I don't have any evidence, really, that's of value. I don't have any randomized trial evidence. I have some case series, I have some prospective series. They're way down there. They may be biased by what they have, so they don't really help us in what to do. But I do have really good data for 2 years. And if people would just get the first 2 years right, then I think we would at least make an advance there. So we're going to work on that today. We only have about 40 minutes. So we're going to work on the first 2 years. Now when you have people that have been coming in already for the last 7 years, I can't help you with that yet. And when you go beyond 2 years with the new person that comes in tomorrow, I'm hoping we'll have new information 2 years from now to help you with that. So I just want to get you through the new people that walk in for the next 2 years. I cannot help you with the ones that you've already been treating for 10 years, and I don't know what's been going on with that. We're going to talk about the new person that walks in. What do you do in follow-up for the next 2 years? There's a lot of choices. So we're going to go through the choices. We're going to narrow it down and hopefully have you walk out of here with some knowledge of how to approach it. You could do monthly dosing. This was done in a Marina trial, the Anchor trial, View 1 and View 2. So Marina and Anchor with ranibizumab or Lucentis, View 1 and View 2 were aflibercept or Eylea. Or monthly dosing was tried in CATT with both ranibizumab and bevacizumab. So monthly dosing works. It requires 12 visits in year 1, 12 visits in year 2, 12 doses in year 1, 12 doses in year 2. That's easy for you, not so easy for the patient. You could do treat and extend. There was the trend study that was done, for example. Okay, if you survey my colleagues in the United States, you say, how many do treat and extend? 85, 90% of them raise their hand. If you then ask them to write down exactly what they mean by treat and extend, and you have 100 people in the room, we get about 85 or 90 different regimens. Okay, so I can go through each one of those with you, but that's not so easy. So most people do treat and extend, which means most people do a different treatment than their neighbor. And so we'll come back to that, but there is a defined treat and extend, and I'm going to review that with you. In the very defined treat and extend that I'll review with you, it was fewer average visits than the bullet above. It's not 12, it was 9 visits in year 1. It was fewer doses. It was 9 doses in year 1 instead of 12 visits and 12 doses. I don't have year 2 yet. It's coming. I don't have it yet. You could do a fixed schedule, but less than monthly doses on the top bullet there. And that's what was done in view 1 and view 2. What did that end up with? That ended up with 8 visits instead of 9 in treat and extend, or instead of 12 with monthly dosing in year 1. It ended up with 12 visits in year 2. It was 12 visits with monthly dosing up on top there, but only 6 doses in year 2 instead of 12 doses in year 2, and only 6 doses in year 2 instead of the 9 that was seen with treat and extend in year 1, but I don't know how many in year 2 with treat and extend yet. Or you could treat as needed. That's what was done in the CATT trial. That was PRN dosing, okay? And what was that? That was 24 visits, 12 in the first year, 12 in the second year, but it had 8 doses in the first year compared to 12 with monthly dosing, or compared to 9 with treat and extend. It had 8 with PRN, and had 7 in year 2. I don't know how many are going to be in year 2 with treat and extend. Could be 9, could be 10, could be 7, I don't know. I do know with PRN it's 7 there, compared to 6 doses when you have a fixed dosing regimen. So more visits, but fewer average doses, and we're going to come back to all these, okay? These are the choices. So it happens that that second bullet, treat and extend, is not just one choice. It's about 72 or 92 choices, but again, we'll come back to that. All right, so let's go to the beginning. Let's start with monthly dosing. That was first tested in Arena and Anchor. Okay, it worked. Monthly dosing works. So here's what they found. They took people that had predominantly classic lesions on fluorescein angiography, and that was treated very well with photodynamic therapy at the time. And if you gave photodynamic therapy, you avoided substantial vision loss. You avoided 15 or more letter vision loss in 64% of the people in year 1, 66 in year 2. That's the green bar. That was our control group, okay? And the treatment group, it was just this dichotomous outcome of who avoided 15 or more letter loss. That was 95% in year 1 and 90% in year 2. So we had treatment A, ranibizumab monthly for 2 years, superior to treatment B, photodynamic therapy. Okay? And that was great. It was a good advance because instead of having 2/3 of the people avoid substantial vision loss, you had 90% of the people avoid substantial vision loss. So that was good. But what was even better is that about 35 to 40% had substantial improvement. How much improvement did we get with photodynamic therapy? About 1 out of 20 people, about 5%. All of a sudden jumped up 8 times to about 35 to 40% with monthly dosing had substantial improvement. Lots of celebration in 2005 when this came out because macular degeneration with our aging population was growing in developed countries, and in developing countries it was growing as well as it was recognized, and as the middle class were growing throughout those areas where they had recognized and a need for having this treatment. So that was a huge breakthrough. There aren't many, but that was one of them. This is looking at the mean change, because what if I told you that also all the people lost a lot of vision, but the mean change went in the same direction. So that gives you confidence that there wasn't harm being done by this as well. Similar outcomes were seen when you look at monthly aflibercept in the view 1 and view 2 trials, and when you look at monthly bevacizumab in the CATT trial. So now we have a treatment that 35 to 40% of the time causes substantial vision improvement, that about 90% of the time avoids vision loss, and all you have to do is treat them monthly for 2 years. So that's really easy. And when that came out, everybody got it, and they said, that's what we're going to do. However, when we told this to our patients, and they already went blind in their first audit, they gladly accepted it. Okay, I'll come in monthly. And they came in the first month, they go, oh, I think I'm getting a little better. They came in the second month, yeah, it's definitely getting a little better. They came in the third month, yep, it's better. They came in the fourth month, no better, but it was better than it was 3 months ago. They came in the fifth month, you know, I'm getting a little tired of this. Well, but really, we're going to just treat this monthly for the next 2 years. Yeah, but I didn't get better than last month. But it's okay, because you're better than a few months ago. Really? I don't remember. No, really. You were 2,200, and you're like 2,080 now. Yeah, but I still can't read the paper. Okay, but you're better. You're 4 lines better if you used to lose vision. Okay, I'll come in for the 6th. Now I'll come in for the 7th. Come in for the 8th. You know, I am really tired of this. Okay? But it's only the 8th month. I need you for 24 months. So that was a problem. And then everybody started talking to each other and saying, this is a problem. You know, I was all happy. It was this breakthrough. I just told you how exciting it was. And now we have a problem because everybody's tired of it. And it's only month 8, okay? So it was draining our resources. We had all these people coming in to be seen for their injections. They had frequent visits with not only an imposition on them, they had to get driven in. A lot of them didn't have good enough vision to drive. Their family members had to take time off to do that. It was costing a lot. The drug cost a lot. The examinations were there. They might have ancillary testing to evaluate whether they were doing well or not. There were small risks, okay? So they might get endophthalmitis, but that was really rare. There were possibly systemic risks, but nothing proven for that. And people, right, people said, oh, I know how to solve this. We'll reduce the number of visits and reduce the number of injections. And that way you won't get sick of it. Everybody happy? Well, if you reduce the number of injections, then you're going to have less endophthalmitis. You're going to have less irritation in that. The question, though, is if I reduce the number of injections, will there be new risks? Will I lose vision? I was all excited because 35 to 40% gained vision. Well, what if I reduce the number of injections and only 5% gain vision? Well, I can get that with photodynamic therapy, and I only have to see it every 3 to 4 months. So is it okay to reduce the number of injections? Well, you'd have to do a non-inferiority trial to test that. So people thought, well, maybe we'll just do a fixed but reduced dosing regimen. I'll give some loading dose where I'm trying to get this to get better, because it looked like in these monthly treatments, for the first few months, the person kept getting better. So why take that away from them? But that we'll do a fixed dosing interval that will have reduced number of injections. So maybe I'll have a loading dose of 3. In the PEER and EXCITE trials, they said, I'll then give it every 3 months. In the VIEW 1 and VIEW 2 trial with the aflibercept, they said, well, then I'll give it every 2 months. So every 3 or every 2, doesn't matter. It's all less than every month. And it would reduce the number of visits and injections. It might be 6 with PEER or EXCITE. It might be 8 by giving 3 injections and then every other month in the first year. And so this was the PEER trial. They gave 3 injections. People started gaining vision. Then they said, I'll give it every 3 months. And now people started losing vision. So yes, the patients were tired of it. And so they liked this more. It's much more convenient. It's not as good for their vision. If you said, well, how many of them gained 15 or more letters? It wasn't 5% with photodynamic therapy, but it was 10%. It wasn't 40% like we saw with monthly treatment. And so this was more convenient, but it certainly wasn't non-inferior. It was inferior for their visual acuity. So you could weigh with the patient, okay, I know you're tired of this. I know I've done it 4 times to you already. Do you want to come in every 3rd month? You have less of a chance of having good vision, but you know, you won't be tired of it and you won't complain. So now we had some data to say maybe you can't do that. So do you want to give up on the chance of improving vision? The EXCITE study confirmed this. It looked at ranibizumab and it looked at a monthly dose compared to every 3 months. And what they showed is that the monthly dose kept going up in those middle months there, and with the less than monthly dosing that was given, it was given quarterly after 3 injections, it started deteriorating. And these oscillations that you see in below with the OCT, getting thicker and then inject and it gets thinner, getting thicker and then you inject and it gets thinner, that could be associated with some of the permanent scarring that was happening in between those 3 monthly visits. So not every 3 months, how about every 2 months? Can we take that chance? So that was in the VIEW 1 and VIEW 2 trials. And what they looked at in the first year was trying to give it every 2 months, not from the beginning. First they gave 3 injections, and then they gave it every other month, and that would mean 8 injections and 8 visits. and that indeed was non-inferior, and now you know what that term means. The visual acuity was non-inferior to monthly dosing with ranibizumab or with monthly aflibercept. And that was in the first year. Now, in the second year, they saw them every month. They went to a PRN schedule. They called it a CATT PRN schedule because they saw them every month in the second year, and they treated them at least every 3 months. So these are 8 treatments in the first year, and you had to treat at least every 3 months in the second year. You might treat more often if you saw problems in between. So the visits were every month. The treatments were at least every 3 months. It might be more if you saw activity there, and that's how they were treated. So in the second year, it became monthly visits, not every other month, like in some of those times in the first year. And it was a capped PRN. That is, it wasn't exactly as needed. It was as needed, and you had to give it every 3 months if you hadn't given it. And that was non-inferior to monthly. So that was good. That was great, because we not only could get those outcomes that we had with monthly treatment, we could reduce the frequency and the visits. But by how much? 8 visits and doses in the first year, 12 visits and 6 doses in the second year. 20 total visits, 14 total doses. So when the patient came in, if they said, well, I hope this isn't going to require too many injections, we'd say, no, it's not 24, it's only 14 over the first 2 years. So, oh, I can do that, because they don't want to go blind like they did in their first year. So they come in for their first injection, then the second, then the third, and they say, okay, now I'm going to see every other month. Okay, they come in at month 5, at month 7, and now I'm getting a little tired of this. But wait a minute. If I do this less frequently, you're going to lose vision. Okay, I'll come in. And then in the second year, to follow them monthly was what was done. They say, well, do I have to come in monthly? Well, I don't know what would have happened. I don't know if it would have been non-inferior if they came in less frequently. So the next approach that was considered, rather than a reduced fixed monthly, 3 months is too long with ranibizumab, every 2 months was okay with aflibercept. The next approach was to say, well, why don't I just give it to you as needed? So this started with a loading dose, and this was reactive. It said, don't treat after that loading dose. It might be 1 loading dose, it might be 3, but don't treat unless you still see VEGF activity. So you saw them monthly, constantly looking for activity, but you'd only inject them. So for the person who just doesn't like that injection, you were potentially able to treat them less. I'll show you how much less, but you still had to see them monthly. So maybe they didn't get tired of the injections. They might say, I'm getting a little tired of coming in here. And maybe the food's not so good where you have in your cafeteria or something. So we had to do something to keep them. But that was tried in the CATT trial. They were seen monthly, but they were only treated as needed. So there was no reduction in the number of visits. And I already told you this as we were talking about non-inferiority trials. When you gave monthly ranibizumab, you had a gain of 8.5. When you gave as needed ranibizumab, so you saw the monthly, but you only gave it as needed, you had a gain of 6.8. The difference between those is 1.7. That's just the point estimate. You know by now that doesn't tell you. You have to look at the 95% confidence interval around that point estimate. And does that cross 5? No, it didn't. And so this gave us a way of treating only as needed and get non-inferior vision. How many injections? It was 8 instead of 13. So they gave it every 4 weeks. So that's why it was 13 injections through 52 weeks versus 8 injections when they did this, see them every month and only inject when you see activity. On average, they gave them 8. That was on average. Some people got 2. Some people got 13 because every time they came in, they had activity. The average was 8. But it gave you the opportunity to give some people less, and unfortunately, some people had to get more, but the average of the visual acuity was non-inferior there. And as I said, they did 6 comparisons, so they had to look at the 99.2% confidence interval there. And that was sustained after 2 years, as we said, for the ranibizumab as needed. Not bevacizumab as needed, but ranibizumab. And we learned from this trial that that would mean 24 total visits. They had fewer average doses of 8 in the first year instead of 13. 7 in the second year instead of 12, okay? So 15 average doses over 2 years. I have to see every month, but on average, I'm going to treat those people 15 times. Some less, some more, but on average, fewer than the 24 to 25 that you might have to do if they came in every month. So it was a step in the right direction. So fixed dosing was a step in the right direction. It wasn't a lot less doses. PRN was a step in the right direction. And that's where we were so far. We learned that fixed monthly works with either aflibercept, bevacizumab, or ranibizumab for at least 2 years. We learned that fixed monthly works with a fixed dosing that was less frequent than monthly thereafter, every other month for at least a year, followed by a CATT PRN. We learned that as needed with ranibizumab work with fixed monthly visits for at least 2 years. And after 2 years, we don't know. None of these trials maintain the randomized trial information after 2 years. But what about treat and extend? What about this regimen that most of my colleagues told me they did? What was that? That was where they gave some loading dose, and then they would keep treating monthly until there was no longer any VEGF activity. For some people, that might happen after the 3 doses. For some people, it never happened. They kept giving monthly doses forever. And for other people, it was everything in between. And when they saw that there was no VEGF activity, they still injected them. That's how it was different from PRN. In PRN, when there was no activity, they didn't inject them. They said, I'll just see you next month. But they saw them monthly to watch very carefully in this disease. In this case, they would say, I see no activity, I'm going to treat you, but I'm going to extend it by 2 weeks. And when they came back, if there was still no activity, they said, I'm going to treat you and I'll extend it by 2 weeks. And they would extend it as long as 3 months. So they could identify some people who only needed it every 3 months, some people who needed it every month, and some people it just fluctuated in between. And if they went to, let's say, 10 weeks and they came back 10 weeks later and now there's activity, they would treat them again because they were always treating them. Treat and extend was always treating them at every visit. It's just they might extend the visits, but if they saw activity come back, they would say, I'm going to treat you, but I'm not going to wait 10 weeks to see you now, I'll see it in 8 weeks. And if they came back in 8 weeks and there was still activity, they said, I'm going to treat you again, but I'll see you in 6 weeks. And they might come down as small as 4 weeks again. And so it would go up and down and up and down and up and down. Okay? That would again reduce the number of visits. So it's a proactive rather than reactive PRN to try to treat this at extended intervals, but it's always treating, not deferring it and extending, but always treating. So a variable number of loading doses until there was no activity. Then they would treat it even though there was no activity, but extend the follow-up, and they'd reduce the follow-up if they saw that activity came back. So if you look at the American Society of Retina Specialists or the Canadian preference and trend surveys, the most popular strategy was this treat and extend, but it wasn't as regimented as I just showed you. And the evidence wasn't very strong because it was all based at the time until last year on retrospective case series. Some were prospective case series, and they compared them to historical controls of either monthly or PRN or other fixed dosing. And it suggested fewer visits, fewer injections, but we really didn't have a one-to-one comparison. There weren't randomized trials until this first study, the TREK study. This looked at 60 participants. They gave 20 monthly ranibizumab and 40 treat and extend. Now, why was that? We already knew the safety of the disease. Why is it not one-to-one? They believed that more people would enter the trial if they gave more of the people the easier regimen. But can you really tell a difference if something is non-inferior with just 20 patients? Well, they didn't report non-inferiority. And they didn't show that it was superior. With monthly, it was 10.5. With treat and extend, it was 8.7. This got published, and yet they didn't show if it was superior, and they didn't show that it was non-inferior. So we did our own analysis of whether it was non-inferior, and it was inconclusive because the 95% confidence interval around their treat and extend outcome to their monthly outcome went from minus 9.7 to as great as 6.0. So across that barrier of 5 letters that we think is a likely difference between treatments, So we weren't confident that this treat and extend was necessarily non-inferior. And that's all we had. So that gave us pause. And if we looked at the details of the study, we see that a lot of people were lost to follow-up. So they just did last observation carry forward. But they had 18 people, so these were really small numbers, and yet that's what most people in the world were treating, these 400,000 new cases of neovascular AMD every year based on that. And if you look at the percent that lost 15 or more letters, it only happened in the treat and extend group. Now, we're not confident that's a difference, because it's very few people. I'm just showing you where we were with treat and extend. Well, it got a little better when finally the trend study came out. This was much larger. Okay, this looked at 327 in each group. Now we've got numbers that we can be confident might show us if it's non-inferior, depending on what the visions are. So we had a monthly ranibizumab group, that's our gold standard control in this case. And we had our treat and extend, which was the regimen I just explained to you. Treat it monthly for a few doses and then keep extending by 2 weeks until you get out to a point that there's activity again, and then decrease it until there's no activity, and then increase it again. That was the trend study, and that's what they were comparing. So they had 650 participants. Now we only have 1 year data so far. I don't have 2 year data. And they showed that in the treat and extend group, they gained on average 6.6 letters. In the monthly group, 7.9 letters. Is that a difference? It's a 1.3 letter difference, but with 325 in each group, the 95% confidence interval did not cross 5, okay? And so if we looked at the percent that lost a lot of vision, was 8% in each group, that gave us confidence. And so we were pretty comfortable that this treat and extend regimen was indeed non-inferior to a monthly treatment. But was it different than PRN? And was it different than a fixed dosing that was done in the VIEW 1 and VIEW 2 trials? Well, the mean number of injections was 8.7 in the treat and extend group, 11.1 in their monthly group. Because remember, people are going to miss a visit every now and then. It's hard to come in every month for a year. So you do indeed get 2 less injections. Remember, the whole idea of this was people were getting tired after injection number 3 or 4. Well, if we're going to do treat and extend in this way, it's 9 injections. Not 11, but 9. Is that much better? I don't know. It wasn't as great as a lot of people thought they were getting out of this treat and extend group. The number of visits was 9 instead of 11. Was that really a big difference? Is that a clinically relevant difference? Maybe, but we'll have to think about it. This is what they showed in terms of the mean change in vision, in terms of the percent that gained or lost. And so it told us that there were people who needed fewer injections, but not everybody. So we'll put all that information together, and I'll show you those 4 regimens so you can go home and think about how you want to treat neovascular AMD. There's this formal treat and extend. What do we know? We know in the first year, there were 9 visits, and there were 9 treatments, okay? In the second year, we don't know. So I'm just putting question marks here. Maybe there were 9, and maybe there were 9. And so maybe the total is 18 visits and 18 injections. I don't know, because we don't have the 2 year data yet. It's coming, okay? So now we have fixed visits and fixed dosing. This is from VIEW 1 and VIEW 2. So here we have 8 visits and 8 treatments in the first year, 12 visits and 6 treatments in the second year. So that might be better than treat and extend. It's 20 visits, so it's 2 more visits, but only 14 injections instead of 18. Again, with a question mark on year 2 there. What else do we know? As needed, as was done in the CATT trial. That was 12 visits in the first year, but only 8 injections on average. 12 visits in the second year, only 7 treatments on average. 24 visits overall, only 15 treatments on average. The same as this fixed dosing, and better than treat and extend, if treat and extend is indeed 9 again in the second year, which we don't know yet. The difference between line 2 and line 3, if you look over to the total number of visits, is you have 4 more visits over 2 years. So you have to weigh that. Okay, that's not as good. But you have the same number of injections. 14 or 15 is about the same. So what's the difference? That's the average number of injections. So some people got 15, some got 18, some got 24. Okay, that's the average, 15. But some got 10, some got 5. So what the PRN allows you to do is it says to a patient, I'm going to see you monthly for 2 years. And if you only need a few injections, I'll identify that. And if I do any other regimen, I wouldn't be able to identify that. If you need a lot of injections, I'll identify that. And the vision will be non-inferior compared to if I do monthly. If I do the middle one, the fixed visits and fixed dosing is done in view 1 and view 2, I also will have 20 visits, but I know I'll have 20 visits, not 24. And I know I'll have 14 injections, not 20, but also not 5. So they're just pluses and minuses to row 2 and 3 here. And how about monthly? Well, that's 12 and 12 and 12 and 12 and 24 and 24. So that's where we are. So you could do monthly, but you get non-inferior results with rows 2 and 3. I don't know completely yet if treat and extend will give us the same thing. It's going to have to be really great in the second year to beat rows 2 and 3. It probably won't. And so we're probably going to think about rows 2 and 3. And those are 2 different approaches that you could do with the patient. And maybe for some patients, they go, well, coming in every month doesn't matter. If that's going to give me the opportunity to maybe get fewer injections, that's great. And then we say, well, you know, your eye may need more. And then they might say, well, I'm coming in monthly anyway. Or if they're going to come in for a fixed visit, fixed dosing, it takes away their chance of maybe only needing 5, 6, 7, or 8. That's not most people, but it is 15 to 25% that need fewer injections, and you won't be able to identify those with your fixed visit and fixed dosing. Now, what about beyond year 2? Well, that's easy. We don't know. So what I do is I look back over those last 2 years and say, how often did I have to treat that person? And what was going on? And that might give me a judgment if I can go every 8 weeks with them, every 6 weeks, every 10, every 12. So we'll make some judgment, but we don't know if that's the way to do it. We have no idea. And so hopefully the network and other groups that are working on this around the world will come up with regimens to tell us, because these patients don't just live for 2 years. Typically, the actuarial tables say if you make it to 75 or 77, which was the average age people walk in with this, you're likely going to go at least another 10 years to 87. So you might make a judgment based on the first 2 years. We just don't know. You could do whatever your survey says to do that, and that's all we know. So thank you very much. We can do a question or two before your break, right? I think you're going to take a break in a few minutes here. Go ahead. Or no. Go ahead.
Studies that are done in the US are actually done with the 0.3 milligrams ranibizumab, as opposed to the 0.5 that we get outside. So is it okay?
I think all of these studies were done with in macular degeneration with 0.5 ranibizumab.
But in real practice in the US, we would be using 0.3 milligrams.
It's only for diabetic.
I think in the United States, people, if they're going to use 0.3, typically only do that for diabetic macular edema. I wasn't talking about that yet. I was only talking about macular degeneration here. And even though both diseases use anti-VEGF, that's where the similarities end. So tomorrow it's going to be a whole different story with diabetic macular edema. It's sort of like treating a sore throat with penicillin and treating a deadly pneumonia with penicillin. Same treatment, totally different stuff going on there. Yeah.
So anything promising in dry AMD if patients have a geographic atrophy? There are a lot of clinical trials going on, but do you recommend anything conclusive?
For geographic atrophy, we don't know why there's geographic atrophy. So at least we made a guess, or smart people figured out, that choroidal neovascularization is due to the production of vascular endothelial growth factor. And if you inject anti-vascular endothelial growth factor to mop up the vascular endothelial growth factor, you might not get as much scarring or destruction of the retina, and it worked. We don't know why drusen cause geographic atrophy. They do. We know that it happens over a decade or two, but we don't know why. And so one theory was that maybe it's a disturbance of the complement system. And when one anti-complement agent was tried, it didn't work. There's another one that's being considered. I want you to think about this, and the other agent that's being considered. They showed that it was superior, that there was less growth of geographic atrophy to 1 year when they gave the agent compared to the control. In that trial, they enrolled patients that had geographic atrophy in both eyes, or that had neovascularization in one eye and geographic atrophy in the other eye. When they had neovascularization in one eye and geographic atrophy in the other eye, and they got this new anti-complement agent, they were more likely to get neovascularization in that second eye. And yet, the group that got that agent had less growth of their geographic atrophy. Well, guess what? If you got neovascularization in the second eye, which happened like 10 or 15 or 20% of the time, I don't remember. If you got that, they stopped measuring your atrophy. They just used last observation carried forward. So if you get more neovascularization in the agent group, the active agent group, and you halt their measurement at 3 months, and you say that's their measurement at 12 months, last observation carried forward, who do you think had smaller lesions over time? The ones that got more neovascularization, where you dropped out their data and just froze it to 1 year. That might be why it worked, or it might be that it really slows it down. But we don't have a lot of confidence that that did that. So we need some other treatments to come forward. There's lots of candidates being thought of. Nothing that works so far. And I'll remind you that the dietary supplements that ASRS looked at reduced the risk a little bit of developing choroidal neovascularization. It had no effect on the growth or development of geographic atrophy. So right now, geographic atrophy, most importantly, the management is to explain to the patient that there is no treatment. They shouldn't think these vitamins they're taking are affecting it. It's not. We know it's not, so they should know that. And they should know that we're working on lots of treatments, but there is none right now. So I always warn them, if somebody comes to you with a treatment, please call me up, let me hear. I said, we may not know everything that's out there, so I want to know, but I don't want you to take something that may harm you as well. So unfortunately, no treatment yet. Hopefully, not yet.
Thank you, sir. Another question. So how are these intraocular lenses have come in for patients with ARMD? So they have some telescopic designs and some use prisms.
Yep.
So with a preferential retinal focus, they take the paramacular areas and increase the field.
Yes.
So how practical are those lenses?
They are not very practical at this time, because think about when somebody puts up a telescope in front of their eye, they get tremendous magnification and they lose all their peripheral field. So they are okay for a patient that cannot lift up and put down a telescope to their eye, because that's what it does. It allows them to always have that there. So they have to give up the peripheral field in one eye. They maintain that in the other eye so that they can have this constant magnification there. Well, I worry about losing that peripheral vision if you could just lift up a telescope and put it down. So it's not that practical. But there are people who, for example, have had strokes and can't do that, and need the ability and prefer the ability to have the magnification at distance always built into one eye, and they'll just depend on that other eye for everything else. And so for those people, and it's about, in my opinion, 1 in 500, but not 0, it's worth doing, so at least we have that available.
Thank you, sir.
Go ahead, and then over there, yeah.
The previous lecture you told us how to interpret clinical trials and you put your patient values into it. Now considering the data that we have for AMD, how do you suggest that we put clinical values, patient values?
Typically, the way I explain it to a patient when they walk in is I tell them that we're pretty confident that if you leave this alone, about 70–80% of the time you're going to lose a lot more vision. And if I treat you, your chance of losing vision is only about 10%. So about an 8 out of 10 chance of losing a lot more vision versus a 1 out of 10 chance of losing a lot more vision. But in order to get it down to 1 out of 10, I'm going to have to see every month for the next 2 years. And I don't know about thereafter. I tell them maybe there'll be some other things that come along. And I have to treat you, on average about 14 times over those next 2 years. That's number one. Number two, that it's not likely you're going to see better, but there's about a 40% chance that you'll have some improvement in the vision, that you might be able to function a little better. They all think that's going to be them, but that also means 60% are not going to see better, so I remind them of that and say, about 60% of the time you won't see better. Now, if your insurance will cover that, then that won't be a burden to you, only to your insurance company. If your insurance won't cover it, then we have an agent that we have to use monthly, bevacizumab, and I'm going to have to just treat you monthly for the next 2 years, because if I use it less than monthly, I'm not confident you'll get those same results, and that's the discussion. For most of them that have insurance, they'll take one of the more expensive agents so that they can have the opportunity of being injected less. For a few of them that don't have the insurance, then they'll typically accept just having monthly bevacizumab for 2 years, but the expectation has to be painted up front. So when we first have a new patient who we're going to start treatment, that person needs 10-15 minutes of a one-on-one discussion, and then a reminder of that for the next few times, and then they pretty much get it down to understand it. And hopefully, if you start somebody like that, 2 years from now, we will have something that will reduce it further. We may not, but we'll cross that bridge. I'm just catching you up to where we are right now in August 2018, and that's the values. Yes.
Thank you, Professor Bressler, for your wonderful talk. And I have 2 questions for you. The first is that you have talked mainly about the clinical trials, Regimen control trials especially, but we all know that there's a gap between the Regimen control trial results from the real-world studies. So what do you think about the real-world studies? And
Good. Don't ask the second one yet, because I'll forget the first one. All right. Remember, 12-hour difference, right? Okay. All right. Real world. Well, first of all, I won't win this battle. Do you know the story of Don Quixote? So he's this person that went on a quest, and there was just no way he was going to succeed. No way. But he was fixed in his ideals, and he did that. So my chaotic approach is not to use the term real world, only because I deal with a lot of people who participate in clinical trials. And if I told them they're working in a fake world, they'd be insulted. They're volunteering for us. So just out of respect to them, I just want to let you know, and I won't win this. I try to encourage people to talk about in the clinical practice setting and in the clinical trial setting. But it is purely out of respect to these people that have volunteered to give us all these data to help everybody else. I just wanted to say that. But that was like a Don Quixote, I won't win thing. All right, so in the real world, we have learned that outcomes are not as good. All that means is that either people have not recognized what's important, or the trials entered people that are different from what's out there in the real world. I think it's the first. I think the cases that were enrolled in the trials are likely the same as the cases that you and I are seeing right now. The difference is, if you also look at not only the visual acuity outcomes, but how often they treated, they may have treated in the first year an average of 4 times. They may have treated in the second year an average of 2 times. Well, look at that trial where I showed you they went every 3 months with everybody. The vision went down. So actually the real world was the same as the clinical trial setting. It's just that people didn't recognize, perhaps, or didn't reinforce that you need to treat these people almost every month, or maybe see them almost every month, and that wasn't recognized. So if you also look in the clinical practice setting at people who decided, I'm just going to treat every month, the cases are doing the same. So we need to educate our colleagues of where we are with macular degeneration. It's a mess, because if you don't do that, the costs are very high. In other diseases, let's say diabetic macular edema, if you fail to treat it as carefully, you may not have as many failures. And so that's why people say maybe it's more forgiving to treating it in a incorrect way. Whereas here, if you treat it in an incorrect way, there's more to lose. So what I think is we have to educate our colleagues that get over it until we have some other way. You either have to see them monthly or see them almost every month. You have to treat them monthly or almost every other month. And until people accept that, they're going to have worse results on average.
Thank you. And the second question is, you have mentioned different kinds of follow-up regimens for patients. But the one thing you didn't mention today is there's another study focusing on the OCT biomarkers that may personalize every treatment for each patient. So do you think there's a value to for us to use OCT guide treatment decision that we can decide for this patient he should go for monthly or bi-monthly or treatment stay or PRN?
Right. So if you don't have a control group, then however your patients did, you can assume was better than they would have done had you done something else. So the biomarker studies that have been done are great hypotheses, and they then need to be tested. Okay, if I use my treatment based on that biomarker versus I use my treatment based on everything but that biomarker, do the results come out superior? And if so, then those are better biomarkers. We don't have such studies so far. We only have the hypotheses, which are good, and I think they should be tested. But for right now, there's no evidence that that's any better than the approaches that I told you. And the worst thing would be if it's worse. That what if indeed, instead of 40% gaining 15 or more letters through 2 years, using that biomarker, only 20% gaining 15 or more letters. You'd never recognize that in your practice. You need several hundred new cases to see that. But really, would your patient standing in front of you want to use that biomarker decision because you say, well, instead of 40% of the time you're improving 3 or more lines, you're only going to improve 20% of the time. Do you think they'd want that? I don't think so. So we need to know. So to me, these are really good, but to me, they need to be tested. Now, one of our weaknesses has been we haven't been as organized in testing new treatments for macular degeneration. So the industries have been very strong in getting treatments approved, but those approval trials aren't necessarily the most friendly way of treating the person. So we need to test lots of different regimens. Now the trend was one such trial to look at that treat and extend. That was a way of looking at it. View 1 and View 2 was a way of looking at fixed but extended dosing regimens. The DRCR network that started just in diabetes and came up with a lot of management from that is now going to walk into the macular degeneration realm and start to find ways of improving our treatments there. So we need those sort of organized groups to give us better outcomes, to start rapidly testing these other hypotheses, which I think are great, but I wouldn't apply them yet.
So do we have any data from these RCTs on the increased incidence of geographic atrophy with these injections?
Yeah, we have a lot of information so far. The information suggests that the more atrophy you have, not geographic atrophy, the more atrophy you have, the better your vision. I'd say, how could that be? Well, let's think about it. The CATT trial showed that in the monthly arm, there was more atrophy. Everybody got scared and said, oh my gosh, I give 24 doses, I'm getting more atrophy. Well, it's also true that the monthly arm had the best vision. So should you worry about having atrophy? Maybe if you have atrophy on a photograph, that just means you didn't have a chance to scar the whole thing. So you have to know what's the vision, not just is there an anatomic effect of atrophy. An analogy might be when you put in PRP to somebody with proliferative diabetic retinopathy, you have a whole lot more atrophy and scarring of the peripheral retina 3 months later than if you didn't give them PRP. But who do you think has better vision 3 months later? The ones that have that peripheral atrophy. So I'd rather treat monthly and have more atrophy if my vision's going to be better. Now, the question is the agent causing atrophy, or do do you just have more atrophy because you avoided scarring in the eye compared to not giving the agent as frequently? And we don't know right now, but a lot of things that go against the fact that it's causing atrophy are as follows. If somebody has a lot of geographic atrophy in one eye, and the other eye has choroidal neovascularization, when you inject them, you don't get more growth of atrophy in that eye than the additional atrophy that's happening in their fellow eye. In other words, if you follow areas, let's say out by the arcades, and you look in the right eye where there's no neovascularization, you see slowly but surely they're getting more and more atrophy. It's growing at this rate. You look in this eye, it keeps getting injections, and you look out by the arcades beyond the neovascularization, and that atrophy is also growing at the same rate as this eye. So it suggests to us it's not causing atrophy, because the rate is the same in both eyes. And that's why we don't think so. Also, we give lots of this treatment to people with diabetic macular edema. They don't get atrophy. We give lots of this treatment to vein occlusions. They don't get atrophy. You might say, well, because they don't have drusen. It's only a problem if you have drusen. Okay, if that's true, I would have expected more geographic atrophy in that fellow eye when I can compare them. So I do think you get atrophy over the neovascular lesion because you're preventing scarring, but I don't think you're causing more atrophy, let's say in areas that don't have neovascularization there. And by causing atrophy instead of scarring, you end up with better vision. So it's the price we pay. What's going to happen is we might see that even after 5 to 10 years, everyone starts to lose vision, because while you preserve the retina from scarring, it might just be that the tissue disintegrates away anyway, in spite of, not because of, but in spite of the anti-VEGF being given. All right, so I went over by 11 minutes, so we're going to take one last question here. Yep.
So if we see a new vessel on OCT angiography and no SRF on OCT, so should we treat those cases? Or we
Yeah.
see a choroidal neovascular membrane?
I wouldn't. And if I saw one on fluorescein angiography and they're 20/20 and they have no fluid, I wouldn't treat them. So the fact that we used to watch cases of occult choroidal neovascularization on fluorescein without fluid, without vision loss, we used to watch those. I'm not going to change that just because now it's another mechanism that shows me there's choroidal neovascularization there. I know it's there. I wait until there's some progression with some vision symptoms. And so I would follow those people carefully, maybe in a month the first time or the second time. If it doesn't change, maybe 2 months after that. If it doesn't change, maybe 3 months after that. If it doesn't change, maybe every 3 or 4 months indefinitely. But I wouldn't treat it at first just because it's there. Just like we didn't treat it for the last 20 years when we saw it on fluorescein angiography, but there were no symptoms and there was no fluid. Okay, you all were great. It was pretty good to the end of the afternoon. I know you still have to go after tea, but I'll let them do the break. Cindy, you're all set out there? Let them go? All right, thanks again.